All right, you know that moment when you're staring at a completed chart, you're looking at your CPTs and thinking, think I need to add a modifier, but you don't really know which modifier to add. So you put in a modifier, then maybe you delete it, and finally you throw something down and you just hit the submit button and close your eyes and hope it doesn't get a denial. I get it. Modifiers suck. So many rules to remember and so many nuances around what modifier to add and what CPT to add it onto. So today we're going to dive into one of the most misunderstood and misused modifiers in medical billing, and that's Modifier 59. If you've ever heard someone on your team say, just add a Modifier 59 and it'll get paid, this episode is for you. So by the end, you'll know exactly when Modifier 59 applies, when it doesn't, and how to use it correctly to protect both your revenue, as well as making sure that you're not putting stuff down unnecessarily, which could potentially flag a compliance audit. So we're going to talk about what Modifier 59 actually means, and then we'll talk about how to use it in different subspecialty scenarios. If you guys don't know, we are a full service medical billing company. We have about 70 employees now. We have about 27 groups and serve many different subspecialties. If you are looking for a full service medical billing team, head on over to our website, NatRevMD.com. Check out some of our free resources, including a medical billing course. And also head on over to the page where it says free revenue audit, and you can see if you qualify for a free audit. Let's start talking about Modifier 59. All right, let's start straight from the CPT and Medicare definitions. So Modifier 59 is defined as a distinct procedural service, indicating that a procedure or service was distinct or independent from another service performed on that same day. Now, it goes further to clarify that this distinction may actually be to things such as a different session or a different encounter, a different site or organ system, a different procedure or surgery, separate incision or excision, a separate lesion, things like this, or even a separate injury or area of injury. Now, that's all confusing, so we're going to go into some of the examples in a minute. So Medicare also adds in a little bit more detail, and they talk about Modifier 59 should only be used when no other more specific modifier applies. Now, there are other modifiers like XS, XE, XP. We're not going to talk about those today, and those are very limited to certain scenarios. And the struggle is not all payers accept those. And so you get into a situation where 59 can be default, and that's not necessarily wrong. And again, remember a few weeks ago, we talked about if you have a modifier and you add something on, you're either going to get paid or you're going to get a denial, right? And the denials are what you worry about. Obviously, if you get paid, they're not going to pay you less because you added the wrong modifier. They're just not going to pay you at all. Now, some modifiers do change the payment of a service, like a Modifier 25, where potentially subsequent CPT codes may not result in a full paid amount of the service. Those are just some nuances. But today we're going to, again, focus on that Modifier 59, when to use it, when to not use it. So here's a nuance that we get asked all the time. If I use a 59 instead of one of the X modifiers, does it change payment? Again, usually no, it doesn't change what gets paid, but it can affect whether your claim gets through the payer's edit logic and gets a denial or not. So sometimes using a Modifier 59 will flip it to a denial. We'll flip a denial to a paid claim depending on the payer's rules. Of course, Medicare does prefer those X modifiers, but it doesn't reject a 59 modifier outright. So commercial payers are obviously going to vary. Some are going to recognize 59, so it just depends on the payer. But either way, the documentation must prove that those services were truly distinct, and that's what we're going to focus on today. Think of 59 as that modifier of last resort. Only use it when nothing else fits. So we're going to talk about different subspecialty scenarios when it comes to using this modifier, so you can think about how it fits in real life. So first, we're going to kind of talk about urgent care, primary care example. So patient comes into the urgent care with a laceration on the right hand. Say they also have knee pain on the left leg. So you perform a wound repair and take a knee x-ray, right? Two separate things that are completely unrelated, different sites, different reasons for care. Adding a Modifier 59 to the x-ray is appropriate. It tells the payer, yes, these are actually separate services with two different things going on. Now, here's where things go wrong, and I see this happen frequently. Patient comes in with dysuria. So you order your analysis, right, which is that 81003 CPT code, and then someone adds modifier 59 to make sure that it gets paid. And that's where things are not correct, right? So, and sometimes people do that because they don't want your analysis bundled into a different service. Now, the UA typically isn't a distinct procedural service, right? It's a diagnostic test. And so modifier 59 doesn't apply here. Now, same goes for a visit where the team runs a strep, flu, and COVID tests at the same encounter. You can't just add a 59 to each of those codes to bypass payer bundling. CMS already defines which tests are separately payable, so modifier 59 isn't going to override those bundling rules. And this is kind of one of those compliance mistakes that we see folks making. Makes sense. I totally get it. And that's why we're going over these things. So using a modifier 59 on labs when it doesn't belong there is something to watch out for. All right, just a quick pause to remind you guys that we do have a free eligibility checklist. This is something that we commonly see as a struggle in many of our practices, is just the training and the competency with regard to eligibilities in the front office staff. So if you are wondering on whether or not your team's eligibility checks and billing workflows are actually working, grab our free eligibility checklist at natrevmd.com/eligibility billing verification, or check out the link below. It is one tool that you can use to train your staff and make sure that they know what they're doing, so that you're not losing money on the back end. Back to the show. Let's now talk about orthopedic examples. Orthopedics is another practice that we bill for, and this is another area where you can use that modifier 59 inappropriately. So an orthopedist injects the right shoulder, say they also inject the left elbow at the same visit. Now, two different anatomical areas, two different procedures. So say you code the 20610 for the shoulder injection and the 20550 for the tendon sheath. That's where a modifier 59, or preferably an XS modifier, depending on the payer, applies to the second code, because they're truly separate. But here's where people oftentimes get tripped up. So if you inject two spots within the same shoulder joint, that's still one anatomical area. So added a 59 there doesn't suddenly make it two billable services. It's still one procedure. Using a 59 would then in that scenario be incorrect. Now let's talk about GI. Lots of folks have questions about this. So it's important to think about, say you're a GI and you're doing a colonoscopy, and you have a polyp in the ascending colon using a snare technique, and you take a biopsy from the sigmoid colon as well. Now, those are two separate lesions, separate anatomical sites, so 59 on the biopsy code is correct. But if both the biopsy and the polyp removal are from the same lesion, then it's just one service. So in that second scenario, adding the 59 would be not correct. And this is one of the important things to make sure that folks understand. All right, now let's talk about OBGYN. This is actually a very common practice for us. We have a ton of OBGYN practices, large practices. We actually have an amazing, incredible team who manage our OBGYN services. Not that we don't have amazing teams doing our other services, but we do have an incredible OBGYN niche that we've created. So say an OBGYN performs an endometrial biopsy, right, 58100, and a pelvic ultrasound 76830 at the same visit. That ultrasound is done for guidance of the biopsy. It's bundled. You can't add a 59 modifier to it. Now, if the ultrasound is diagnostic, say the patient has pelvic pain, you're evaluating that separately, then a modifier 59 is appropriate. So, but you've got to make sure your documentation makes that super duper clear. So you've got to kind of walk through that within your documentation, talking about the pain, talking about the diagnostic tests you're doing, talk about the tests you performed, the outcome, and then therefore the treatment. And this is also where confusion happens between modifier 59 and modifier 25. So if you're doing an E&M visit with a minor procedure, like a biopsy, modifier 25, not 59, should therefore be used. So you've got to pick the modifier that tells the most accurate story, of course. All right, so let's reframe this and just provide some guidance on how to think about modifier 59. So here's the mindset I want you guys to really think about. why was the service done, right? First and foremost, if it's for the same reason, it's going to be bundled. And so adding a modifier onto it is not going to, maybe it'll get paid or maybe it'll get triggered. But if it's not truly for a separate service and you do get audited and you don't have the documentation, they'll come back and they will bundle those. Now, the second thing to think about is where or when was it done? Different site or different encounter? Now you may be in the Modifier 59 territory. And then last, what does your documentation actually say? If your note doesn't make that distinction clear, you can't justify the modifier. Now, how often are you using these modifiers? Overuse is a major red flag for payers. So you want to make sure that Modifier 59 never belongs on laboratory testing. Labs are defined by CPT and NCCI edits. So you don't need to and shouldn't use a 59 to force a separate payment for those. That's really how those small mistakes can turn into issues down the line. So just leave those out. All right. So hopefully this was helpful. Modifier 59 is not, really all that complicated, but it is a very good tool that should be used when it is intentionally and purposely documented for a separate service and or a separate anatomical site, and obviously that the documentation supports it. So in our next episode, we're going to talk about other common modifiers. All right, thanks so much for joining the show this week. I appreciate it, and we'll talk to you soon.